Good morning, everyone. I would like to thanks to ECCAM committee who invite me to talk about Blalock Taussig Shunt revisited. Conventional doesn't mean more inferior. First of all, we have to understand that nowadays BT Shunt already changed to BTT Shunt. That because the original procedure was named from the three persons: Alfred Blalock, Helen B. Taussig, and Vivian Thomas. Vivian Thomas is the Blalock laboratory assistant. Initial or original BTT shunt was anastomose the subclavian artery directly to the pulmonary artery, like this. But nowadays, we have a conduit, PTFE conduit. We can we can connect subclavian artery to pulmonary artery without cutting the subclavian artery. We call it modified BTT shunt. So this is the original picture, the first BTT shunt who helped Blue Baby, Alien Saxons. The surgery was held on Johns Hopkins Hospital on 29 November 1944. Success, and the patient can discharge on the 2 weeks after surgery. This is Alfred Blalock, Vivian Thomas, and Helen Taussig. Type of BTT shunt, this is the classic BTT shunt. We didn't do it anymore. So, and also the Waterstone shunt and Port shunt, we didn't do it anymore. We just did the modified Blalock Taussig shunt from the subclavian artery. If we want to do the central shunt, we can use the PTFE directly to ascending aorta to pulmonary artery. The aim of BTT shunt, there are four at least. First, to increase oxygen saturation. The second one, to enlarge the pulmonary artery. The third, to do the LV training, especially on the TGA intake septum. And sometimes in adult tetralogy of we understand that most of them has a small LV. So we can do LV training by using BTT shunt. And the fourth is to increase the cerebral and coronary perfusion, especially on hypoplastic left heart syndrome. We call it reverse BTT shunt because the flow arises from the pulmonary artery to the ascending aorta or aortic arch. So this is our current practice, our experience from 2015 to November 2021. The BTT shunt is the third biggest number procedure among all heart surgery, congenital heart surgery. It's around 601 surgery, BTT shunt, but the mortality is still high, 10.9. If we see in detail that actually the mortality was trending down to 5.9%. But the last 2 years, the number of surgery is decreased due to the pandemic situation. So BTT shunt is about learning curve. It's also for PDS10, it's about learning curve. But the difference is we teach the BTT shunt since the resident. Different with PDS10, they have to do the fellowship, and because it's require advanced tool and also cath lab. So comparing this, BTT shunt is better than PDS10. How about the other aspect? From the circulation 2018 to compare the PDS10 and modified Blalock Taussig shunt as a palliation for infant with drug-dependent pulmonary blood flow. So it's from 4 institutions, there are 106 patients with PDS10 and 251 with BTT shunt. So we can see here that the mortality between the PDA and also the BTT shunt is not significant, so it's similar. Yeah, but for the re-intervention, it's higher on PDS10 side. How about the other aspect? Yeah, PDS10 is better in 2 criteria. ICU stay is better here. Yeah, you can see here it's significant, 4.4 compared to 8.9. And also the pulmonary artery symmetry index, it's better on PDS10. it makes sense because PDA stent is on the central of the pulmonary artery. So it can give same flow to the both side of the pulmonary artery. It's different with the BT shunt because we have to show the anastomosis side, so it can cause constriction in that side. So PA will not sometimes asymmetric. The other aspect, this is a systematic review and meta-analysis, same like before, comparing BTT shunt and also the PDA stent on drug-dependent patient. So from this data, for complication and medium mortality, it's better on PDA stenting side. Early mortality is the same. And for reintervention, it's less on the BTT shunt side. So we can conclude from the data that for ICU stay, PA growth, complication, it's better on PDA stent side. Mortality, no significant difference. But for intervention, it's better on BTT shunt. So how about the cost? From also American Heart Association Journal, 2019, it's concluded that BT shunt has a bit high in cost. Yeah, and it can be happen because the BTT shunt require a lot of supply, yeah, a lot of pharmacy, a lot of lab, because hospitalization is longer than PDA stent. If we in our practice, it also same because BTT shunt without CPB require 5.22% more expensive than PDA stent. It's all because without CPB, it will be more expensive if we use CPB. But sometimes we have to use CPB to do the other procedures such as atrial septectomy, sometimes also the pulmonary artery repair. So for complication and unit cost, it's better on PDA stent side. But how about the outcome control? There are at least 4 criteria comparing BTT shunt and PDA stent. For source artery, BTT shunt, we can choose whether want to do the central shunt or peripheral shunt. For PDA stenting, always central because it comes from PDA. How about the conduit size? We can downsize or upsize in BTT shunt, yeah, because we can select the PTFE tube. But PDA stent, it's almost always upsized because if PDA stent is smaller than PDA, it can migrate. Yeah. How about the target pulmonary artery? We can do wherever it is. Yeah. Especially the small PDA, small pulmonary artery. We have to, if we have to enlarge it, just put it on the smaller pulmonary artery. But for PDA stent, it's almost always follow the PDA. How about the patient condition? We can do any kind of patient condition. We can stabilize it with the CPB, but for PDA stenting, it's not possible because unless it's a hybrid procedure, right? If not, PDA stent is very difficult. Yeah, and sometimes PDA stenting require the another access because of its anatomy. So to compare this from the pulmonary artery problem, CPB need, and crash backup problem, so it's better on BTT shunt side. Yeah. In summary, that BTT shunt is better than PDA stenting in many aspects. So we can conclude that conventional doesn't mean more inferior, right? Yeah, but don't forget, PDA stenting is reasonable alternative to BTT shunt. But it depends on the patient specification and also the learning curve of the interventionist. However, the most important thing is the patient. Indonesia has a lot of cardiologists, has also a lot of cardiac surgeon. And For the cardiologists, they have a lot of cath lab all over Indonesia. So hopefully the patient, many patient with congenital heart disease can take the advantage of this situation. Whatever it is, just do it, whether BTT shunt or PDA stent. Thank you.